Hello, my name is Darryl Sneag. Today, it is my pleasure to talk to you about MR Neurography of the Brachial Plexus. I am the Director of MR Neurography and MRI Research at the Hospital for Special Surgery in New York City. I am also an Associate Professor of Radiology at the Weill Medical College of Cornell University. Here are my disclosures. The term MR Neurography was first coined by Howe and others in 1992. In this paper, they describe visualization of the nerve within the rabbit hind limb using a combination of heavily T2-weighted spin echo and diffusion-weighted images. It was soon recognized in the lay press that MRI was a potential modality to visualize peripheral nerves. But since then, it has still been a somewhat latent field, and I consider it falling within no man's land between the specialties of neuroradiology, whose focus is the central nervous system, and musculoskeletal radiology, which the focus is joint imaging. So what are the motivations for MR neurography? Well, firstly, it serves as an important adjunct to electrodiagnostic testing, which comprises both nerve conduction studies and electromyography, or EMG. It is helpful for nerve injury localization, and especially when multifocal or fascicular in nature, in which the direct localization of the lesion can be difficult to pick up with electromyography. It's been shown to influence surgical planning and outcomes, and in doing so, provides a global assessment of nerves and muscle. On this example on the right here, we see extensive active denervation of multiple muscles in the right shoulder region. So let's look at one example in which MR neurography is able to precisely localize pathology and guide surgery. One can think of the peripheral nerve as a coaxial cable comprising multiple fascicular bundles, and each bundle comprising multiple nerve fascicles. In this example, this woman has an anterior interosseous neuropathy in which she's unable to closely approximate her thumb and index finger to perform important daily activities, such as picking a coin off the table or buttoning her shirt. We image her median nerve within the mid to distal arm, and here we see in the magnified inset that not the entirety of the nerve, but only certain fascicular bundles are hyperintense and enlarged, compared to the ulnar nerve on the bottom left, which is normal. And we know these bundles represent the AIN, the flexor carpi radialis, and the pronator teres bundles because of their known topographical arrangement within the median nerve. If we look at one of these fascicular bundles in longitudinal axis, we see multiple areas of severe narrowing or intrinsic hourglass-like constrictions. The surgeon is now able to make a small incision marking the sites of constriction as denoted by the MRI, exposing the nerve, and then finding that particular fascicular bundle and performing internal neurolysis, or teasing out the constrictions, in order for the patient to now regain her anterior interosseous nerve function. I'd like to take a moment to compare and contrast MRI and ultrasound, another modality used to evaluate peripheral nerves. MRI provides much greater contrast resolution as compared to ultrasound. That is, the ability to differentiate the nerves from other background soft tissues such as fat and muscle, and also the ability to accentuate or highlight pathologic changes of the nerve that typically manifest as high T2 signal. Ultrasound affords greater spatial resolution compared to MRI, but this is only true for more superficial peripheral nerves. As the depth increases, so too the spatial resolution will decrease with ultrasound. One could argue that both modalities are operator dependent, although certainly more with ultrasound. In the United States, ultrasound is certainly much cheaper than MRI. With MRI, though, we're able to access deeper nerves. So in this example here, the T1 nerve root cannot be visualized with ultrasound because it's obscured by the overlying rib. Similarly, other deeper nerves, such as the axillary and long thoracic nerves, cannot be detected along their entirety with ultrasound due to their deep course. MRI is much more susceptible to motion artifact, And we use ultrasound generally as a troubleshooting tool when we cannot overcome artifact with metal seen on MRI. At the Hospital for Special Surgery, we have seen a steady rise in the volume of MR neurography cases since 2016, as shown by this chart. I believe this is due to technological improvements in both the software and the hardware side that have given us the ability to provide higher quality images and therefore increase the diagnostic yield. The workflow at times can be complex, but can be divided into the roles performed by the radiologists, the schedulers, the technologists, the scientists, and the nurse. Some important specific roles of the radiologists are to monitor the exams in real time, confer with the referring physician to make sure that the appropriate exam is being performed. The scheduler is to make sure that the exam is performed on a day when it can be monitored or the radiologist is available to monitor the scan, and that appropriate technologists that are trained to perform the MR neurography exams are present. Scientists may be involved to add on additional research pulse sequences after consenting the patient for research. And the nurse is also an important individual in terms of the workflow, as we many times will give intravenous contrast, particularly for brachial plexus exams, as I'll describe in a moment. So MR neurography can be divided into multiple anatomic regions, but essentially it involves imaging of any peripheral nerve outside of the spinal cord. Today, as you know, we'll be focusing on the brachial plexus, and I'd like to highlight certain puzzle pieces that can be grouped into field strength, gradient performance, RF coils and positioning, and sequences and parameters that are all needed in order to, quote unquote, complete the puzzle, perform an optimal exam. Let's quickly review the brachial plexus anatomy. The brachial plexus typically forms by the ventral rami of the C5 to T1 spinal nerves rising from the cervical spinal cord. The nerves then combine to form the trunks, the divisions, cords, and then branches. Injury may result from trauma, such as a motor vehicle accident or sporting event, from inflammation, such as the condition of Parsonage-Turner syndrome that we're actively studying here at Hospital for Special Surgery. The nerves can be compressed in the setting of thoracic outlet syndrome by either anomalous or hypertrophic muscles and bony structures. And prompt, accurate assessment of nerve damage can critically affect both management and outcomes. Proper evaluation requires imaging in planes both longitudinal and orthogonal to the nerves, and this is something I will stress throughout today's talk. So with orthogonal imaging, which typically relies on high-resolution, fat-suppressed two-dimensional imaging, we're acquiring images that are perpendicular to the longitudinal axis. And since the nerves lie very close to one another in terms of the longitudinal axis, and some one behind the other, it's important to evaluate them in cross-section to be able to separate one structure from the next, but also to evaluate the internal fascicular architecture of the nerve. As we showed in the previous example, sometimes not the entire nerve, but only a portion of the nerve or multiple fascicular bundles may be affected. Longitudinal imaging, such as with three-dimensional cube stir imaging, is important to delineate external, extrinsic abnormalities as well as intrinsic abnormalities along the cord. So here we're able to visualize multiple terminal branches and side branches of the nerve. And I'd like to highlight the long thoracic nerve, which traditionally has been a difficult nerve to evaluate as it courses along the chest wall region. We've used these techniques to develop an atlas, which is still under development, led by Dr. Colucci, a colleague of mine, and Dr. Tan, under an RSNA fellowship grant. And here we're able to delineate multiple small nerves arising from the brachial plexus and continuing throughout the arm, the forearm, and even into the hand. We annotate multiple muscles as well and show which muscles are innervated by which nerves, both in orthogonal and longitudinal imaging. I'd like to briefly review the hardware and software considerations for MR neurography of the brachial plexus. We generally like to image at 3 Tesla using one or more phase array surface coils. We use T2-weighted two-dimensional imaging, as I mentioned, for orthogonal visualization. And for longitudinal imaging, this is typically a T2-weighted three-dimensional cube stir sequence. We'll apply advanced reconstruction techniques using denoising and deblurring algorithms that are often backed by AI or deep learning methods. So let's now go over in detail some important considerations. 3 Tesla is preferred over 1.5 T, as 3T provides almost double the signal to noise ratio and allows us to incorporate higher parallel imaging techniques for acceleration or to obtain higher spatial resolution imaging. I like imaging in a wide bore system, which allows us to put the patient in the region of interest at isocenter to provide homogeneous fat suppression and gradient linearity. Stronger gradient performance, as shown in the chart below, enables echo spacing reduction for a given bandwidth to increase sharpness, particularly for fat spin echo images. So again, we try to position at isocenter and sometimes place a shim box over the designated field of view to avoid shading, as we see in this example, and increase homogeneity or improve homogeneity. And lastly, I like to use a system which gives us the ability to easily combine different coils, which is particularly important for longitudinal imaging of the nerves over a long segment. We're sometimes asked to image a branch all the way from the brachial plexus towards the elbow or even to the wrist. So I'd like to next review some coil setups for either unilateral or bilateral imaging in the brachial plexus. We start with the neurovascular coil. This is a traditional setup, and the coils here are rigid. They poorly conform to the skin margins, and they provide poor lateral coverage to evaluate small but important nerves, such as the suprascapular and axillary nerves that allow ones to move the shoulder. They also provide overall low signal-to-noise ratio SNR, as the coils are far from the neck region. Note the gap between the neck and the overlying coil. Another option is to use a semi-flexible torso coil that could be used for either unilateral or bilateral brachial plexus imaging. But these coils are poorly conformable, and particularly for positional changes, they overall provide poor proximity between the coil elements and the skin margins, and poor neck coverage, and low SNR as coil elements are large. My recommendation is generally to provide high SNR is to use 2 flexible coils for unilateral imaging of the brachial plexus to maximize spatial resolution. We place 1 medium flexible coil below the patient or on the back side of the patient, and anteriorly a smaller but still 16 channel flexible coil, so a total of 32 channel coils that provides overall very good SNR for imaging of the brachial plexus. And I'd like to go into a little bit more detail or show you the setup. So here are the 2 flexible coils. So we ask the patient to lie on the table. We have one of the medium flexible coils already set. The technologist is adjusting the coil so it covers the back of the patient from the level of approximately the earlobe to the upper shoulder region. She asks the patient to turn his head to place the smaller flexible coil over the lower neck region and uses a strap to secure the coils. Another option is to use 2 air MP coils. Here the large MP coil, similar to the flexible coil I showed you in the past video clip, is placed posteriorly. The patient is already lying on it, and anteriorly you should place the medium MP coil. The advantage here is it provides more comfort for the patient. It's very easy to manipulate it so that it rests nicely along the neck concavity. And then a third option is to have the patient sitting in the head and neck rests, but here, if one desires bilateral brachial plexus imaging, is to put a medium or large MP coil, depending on the patient's size, anteriorly. Alternatively, can use one of the smaller medium flex coils anteriorly in combination with the HNU coil. So it's really nice on the Premier system. You can use multiple coils and different combinations depending on what you're really looking for. Another technique I find helpful is to use prospective respiratory triggering with a bellows, here placed around the lower chest or upper abdominal region at the site of the patient's maximal excursion. So here's an example of a patient image using respiratory triggering. Here's a magnified inset on the bottom, and then the right without respiratory triggering. And note here, it's almost impossible to delineate the cords of the brachial plexus or the infraclavicular plexus, that is the portion of the plexus running below the clavicle, without the use of respiratory triggering. Two caveats are that this technique relies on a regular rhythm in terms of the respiratory rhythm, and it can be time intensive, especially in a patient with a low respiratory rate. So here is a different example. We see on the left, with the respiratory triggered image, we're able to delineate a peripheral nerve sheath tumor rising from the upper trunk posterior division. It's very difficult to see, or almost impossible to see, on the non-respiratory triggered image. So this is our general protocol at the Hospital for Special Surgery. We first run a localizer sequence, as with any MRI, and then an axial proton density sequence that serves as sort of a higher resolution localizer, if you will, but also provides another means of contrast to look for other pathology that could explain the patient's symptoms other than the peripheral nerves. We next run a two-dimensional coronal image. We plot this all the way from anterior to posterior, covering all the muscles. We're looking for any edema pattern or fatty infiltration that might suggest an active denervation or chronic denervation process, respectively. Next, we'll plot two batches of oblique sagittal T2-weighted fat-suppressed sequences, both proximally and distally along the course of the plexus. And here you can see the approximate times for each of those sequences. And then lastly, a cube stir sequence, which we're able to obtain a much higher through-plane resolution of 1 millimeter, although not as high in-plane resolution compared to the 2D sequences. And then if we need to see small terminal branches or side branches in detail, we'll apply a post-contrast cube stir sequence, and I'll discuss the advantages of that in a moment. So here is a chart just showing an example of the brachial plexus protocol at 3 Tesla, noting the scan times, orientations, and the different parameters. I'd like to next discuss the importance of T2-weighted imaging in MR neurography. Proton density weighted images are the workhorse for musculoskeletal radiology. T2 weighting with fat suppression is required, as T2 weighting accentuates nerve contrast, in which the nerve T2 is approximately 60 milliseconds relative to muscle, where the T2 is about 35 milliseconds at 3 Tesla. Fat suppression is needed as well due to the long T2 of fat of approximately 200 milliseconds. So with T2 weighting and adequate fat suppression, we can simultaneously image both nerves and muscles, so one can think of MR neurography as neuromuscular imaging. So here on the left, in a patient with Parsonage-Turner syndrome, we see multiple constrictions of the suprascapular nerve on this cube stir sequence, and we see accompanying denervation edema pattern of the muscle supplied by the suprascapular nerve, that is the supraspinatus and infraspinatus muscles. Note that the normal muscle is about 35 milliseconds, but it will increase to up to 80 milliseconds and sometimes even more when actively denervated. Let's next discuss some fat suppression options that we have listed here with examples in the same volunteer. So for cube stir imaging, this is our preference for 3D longitudinal images. A T2 weighted two-dimensional Dixon sequence or two-point Dixon technique that is flex on the GE systems is preferred for two-dimensional orthogonal imaging. Chemical fat saturation is preferred where B0 inhomogeneity is not a concern, although this is a major concern in the brachial plexus. As well as we sometimes consider an adiabatic spectrally selective inversion recovery sequence, which provides more uniform suppression than chemical fat saturation, although still tends to fail around the neck region and also incurs a slightly longer scan time compared to chemical fat saturation. One important parameter of selection when imaging the brachial plexus is the echo train length. And for 3D cube stir images, this is something to be particularly mindful of in terms of balancing both the scan time and the sharpness. So in this example, our echo train length is set at 60. The scan time is quite long, over 9 minutes. In the middle example here, we have an echo train length of 130. The scan time is only 4 minutes and 12 seconds on this reformatted image. And then the third example here is an echo train length of 250, a scan time of only 2 minutes and 14 seconds. 2 minutes and 14 seconds, but note that the nerves are very blurry. And so our preference here is this middle set of parameters, where this serves as really the right balance between scan time and sharpness. Another important parameter selection is the echo time, or TE. So here on a sagittal T2 weighted fat suppressed sequence, TE is set at 85 milliseconds. This is respiratory gated as well. See a nice delineation of the divisions of the brachial plexus. The image on the right, the TE has been increased to 150 milliseconds. Note slightly improved contrast of the nerves relative to the background tissues, but note that there is markedly reduced signal to noise ratio SNR. And so we prefer the set of parameters on the left, or a TE of 85 milliseconds. And again, this is a balance of contrast and SNR. Respiratory gating, as we've shown previously, can reduce motion artifact. So here the image on the left is non-gated. The image in the middle is with respiratory gating. And then one other helpful technique, particularly if the patient's respiratory rate is not consistent or very slow, which as I mentioned can occur a very long scan time, is a propeller technique to reduce motion artifact. So intravenous gadolinium can be used as off-label for vascular suppression. When small nerves are traveling alongside small blood vessels, it can be difficult to differentiate which one is the nerve and which one is the blood vessel. So STIR normally employs a recovery pulse, inversion time of 250 to 255 milliseconds at 3 Tesla to suppress fat at its null point, as shown by this blue curve. Note that without gadolinium, the recovery of the blood follows the orange curve, but when we dope the blood, if you will, or inject intravenous contrast, the recovery curve of the blood follows that of fat, or it's very similar to that of fat. And as such, we can use a single inversion recovery pulse to simultaneously suppress both fat and blood. We're also using a longer TE, which also will help to partially reduce the short T2 of blood and suppress the signal from the vasculature. So let's look at one example. In a patient with Parsonage-Turner syndrome, severe shoulder weakness, we see marked venous contamination on this maximal intensity projection cube stir image. And then with the addition of intravenous gadolinium, but yet the same exact sequence parameters, the same sequence, we're able now to nicely delineate the suprascapular nerve and multiple intrinsic constrictions of that nerve. One technique that can be helpful as a troubleshooting tool is a multi-spectral imaging technique. So Dixon can be used around metal. However, there are two caveats. One, you may incur a full fat water swap. So this is actually the water image, which typically is the fat suppressed image, and this is the fat image. So make sure one looks at both when evaluating the sequences. But here we were unable to clear the terminal ends of the brachial plexus as it courses adjacent to the shoulder arthroplasty due to this prominent susceptibility effect for the metal. But using a hypermaverick stir sequence, we're able to nicely now tease out those nerves. I'd like to show you one example of imaging around hardware and the clavicular plate. This is a common scenario in which a patient may have suffered an injury, typically at the time of the accident. So they may have fallen and fractured their clavicle, but also stretched the brachial plexus. They'll soon fix the clavicular fracture, but the patient is still left with brachial plexopathy, and we're asked to evaluate this. So here is a comparison of coronal inversion recovery techniques with a non-MSI and now an MSI sequence. So note with the MSI sequence, you're able to delineate the longitudinal course of the nerves. We use a combination of 2D sequences. Here, a 2D data set that is plotted above the clavicular plate and then below the clavicular plate, and we were able to nicely delineate the nerves. But at the level of the clavicular plate, we really need that hypermaverick technique to clear the divisions of the plexus. So in this case, the nerves were mildly enlarged and hyperintense, but were in continuity. A very common indication for imaging of the brachial plexus is for thoracic outlet syndrome. This is thought to be due to compression of the plexus at the thoracic inlet that causes pain, paresthesias, weakness, and also swelling, particularly when combined with compression of the adjacent vascular structures. It may result from predisposing anatomical variations such as a cervical rib when combined with repetitive overhead motions and exercise. And disputed type thoracic outlet syndrome, in which the electrodiagnostic testing is normal, is most common. Here we show coil placements for imaging of the brachial plexus in the neutral position and in the Aber position, or the position with the arm in the abducted, externally rotated position. And we perform this position to evaluate the costoclavicular interval. It has been shown that in symptomatic patients, as compared to control patients, they have a narrower costoclavicular interval in the Aber position. We can measure this either in proton density images, as shown here in the top row, or more carefully with 3D osteo images, or ZTE imaging, in which formats improve accuracy of measurement and osseous conspicuity. For thoracic outlet syndrome, when a vascular component is considered, we can perform MR angiography using a contrast-enhanced, time-resolved, gradient-recalled echo technique. We use a split bolus technique, that is taking the standard bolus amount and dividing it in half and imaging initially with the arms down, then the arms up. And in this example, we see marked narrowing of the subclavian arteries, more so on the right than the left. Patient with bilateral vascular type thoracic outlet syndrome. Finally, MR myelography, or imaging of the preganglionic segments, can be performed using a 3D cosmic or balanced SSFP technique. We can achieve spatial resolution of 0.5 millimeters isotropic and nicely evaluate the nerve rootlets, which may be injured, particularly in the setting of a traumatic plexus injury. I'd like to shift gears now to talk about reconstruction. And at HSS, we routinely use an Air Recon DL technique. The network operates on raw image data to produce high-quality images, and it was trained using a curated database of more than 10,000 of these high-quality images. So here we input the raw data, it undergoes this reconstruction pipeline, and spits out the final image. So here's one example in which we're imaging the sciatic nerve after it's left the greater sciatic foramen at the level of the ischial tuberosity. Note on the left, the conventional reconstruction. On the right, a much greater conspicuity of the individual fascicular bundles of the sciatic nerve when the data is reconstructed using the Air Recon DL algorithm. We've been using a prototype algorithm, which is now product, to reconstruct 3D images as well. So here on the left, the raw data is reconstructed with a standard reconstruction. And then here on the right, note the much higher signal-to-noise ratio using the AIR Recon DL algorithm. And we're able to incorporate this algorithm into our protocol such that we acquire the images knowing that they'll be noisy at the standard algorithm, but when we use the AIR Recon DL algorithm, we have much higher SNR and therefore can scan faster. I'd like to briefly review how we evaluate the nerve as a radiologist on MR neurography. So first, we evaluate the size, determine whether it's enlarged or not, which is typically seen in the setting of pathology. Its signal intensity, typically hyper-intense on T2-weighted imaging, whether it's contiguous or not. We look at the internal fascicular architecture, and if there's a loss of the fascicular architecture, that may suggest that there's a neuroma or a disorganized attempt at the nerve to repair itself or tumor. Look at the overall morphology, the external morphology. We see a constriction, as I mentioned, in the setting of Parsonage-Turner syndrome. Look at its course. Is it following its expected course, or is it deviated? Maybe it's tethered to scar or bone. Look at the perineural fat planes for any scar or mass. I'd like to next discuss several cases that review some of those parameters that we use to evaluate MR neurography images. This is a 29-year-old female who's into yoga. She underwent shoulder surgery, and this was complicated by right wrist drop and finger weakness. Note the marked narrowing of both here the median and the radial nerves, and this is due to suture material that were placed around the nerves inadvertently. This was subsequently released. This is a 39-year-old man who underwent Hegel repair, that's repair of the capsule, and he presented with a dense left axillary nerve palsy. So note that the axillary nerve takes a sharp J-shaped turn towards the shoulder joint. It should continue in a more horizontal direction towards the quadrilateral space. And this was thought to be due to suture tethering. So the patient went for surgical evaluation and inspection. In fact, the axillary trunk was both scarred to the subscapularis muscle and also tethered. The anterior division was freed from that tethering, from that suture, and the suture was cut and removed. This is a 17-year-old female soccer goalie who had a grade 3 AC joint sprain, note elevation of the clavicle relative to the acromion on the initial radiograph. So here she underwent ligament repair with a single button fixation. On the subsequent MRI, she had denervation, edema, and atrophy of the supraspinatus and infraspinatus muscles, and she was markedly weak. So here, the same patient, we see that graft, and we see it's picked up the suprascapular nerve. The suprascapular nerve is deviated towards the graft before continuing into the notch. I'd like to next discuss Parsonage-Turner syndrome or neuralgic amyotrophy, a condition that myself and my group are actively studying here at HSS. Hourglass-like constrictions, or HGCs, and nerve torsion were reported as surgical findings during nerve exploration for the past half-century, but most as incidental findings without preoperative imaging. Pan et al. In 2011 was the first to connect these constrictions with the entity of Parsonage-Turner syndrome in a series of 5 patients. This entity was subsequently described in multiple larger series, including those with preoperative imaging. So I'd like to show some examples of the most commonly involved nerves. Here, a patient with wasting of the infraspinatus muscle, a suprascapular neuropathy, so denervation of both the supraspinatus and infraspinatus muscles. And here, multiple severe intrinsic constrictions of the suprascapular nerve, which is followed from its takeoff from the upper trunk towards the suprascapular notch. Second most commonly involved nerve, the long thoracic nerve. Here we see a patient with scapular winging. We see denervation edema pattern of the serratus anterior muscle and multiple severe constrictions of the long thoracic nerve. So in summary, brachial plexus MR neurography is an underutilized but highly valuable technique. Optimized hardware when imaging at 3 Tesla, using flexible high-channel receive coils, high gradient performance systems, and software such as heavily T2-weighted fat spread sequences sometimes with vascular suppression, and with reconstruction algorithms that can denoise and sharpen the images are needed for a successful examination. Longitudinal and orthogonal imaging planes are critical to properly evaluate nerve external morphology as well as internal fascicular architecture. I'd like to thank you very much for your attention, and please feel free to email me with any questions that you may have. Thanks again. With symptoms or weakness that may be in a distribution that is not suspected by the physician, or it's not on the referral, and then we'll pick up perhaps denervation of muscle and then can target that nerve that's innervating that muscle. So then like to do dedicated orthogonal imaging to the brachial plexus. So on the bottom left here is the proximal plot. We noted that the patient had quite a bit of motion, at least on the coronal sequence. So one alternative to using a Dixon type fat suppression is to use inversion recovery. So that's shown here. So these are the proximal nerve roots. So here's the first rib. So under the first rib is always the T1 nerve root, C8, 7, 6, 5. And here are the nerve roots coming to the interscaling triangle. And then along the lateral margin or distal will form the upper, middle, and lower trunks respectively. And then the distal plot, similarly, technologists will plot off of, again, the coronal. They may use the axial as well, kind of this plane looking at the subclavian vessels and the nerves adjacent to them to get perpendicular to the nerves. So here, also alternatively, instead of a Dixon type fat suppression, since we're away from the curvature of the neck, you can use a just regular chemical fat suppress technique, but with respiratory triggering. The nerves maintaining their fascicular architecture. Here's the anterior posterior divisions upper trunk, anterior posterior divisions of the middle trunk, and then the lower trunk. It's difficult to separate out the divisions there. But all of a sudden you see that the nerves become relatively hyper-intense. I say relatively because the radial nerve coming off the posterior cord, which is this guy right here, is normal in signal, and the rest of the nerves are hyper-intense. So we follow this distally, and we follow the lateral cord contribution and the medial cord contributions to the median nerve, and we'll form the median nerve there. Now, there's some hyperintensity, but it's pretty nonspecific. In addition to the standard 2D sequences, we also acquire a 3D sequence. And this 3D sequence has been processed with a deep learning reconstruction algorithm, which I mentioned in my talk is now in product. So here on the left is the acquired plane, and on the right, this is the multiplanar reformations. And here, this gives me another opportunity. While this is at 1 millimeter isotropic, so it's a lower in-plane resolution, we have much higher through-plane resolution. We have, as you'll see, very broad coverage, right? We're covering the neck region all the way into the shoulder, into the upper arm. And this is afforded by the Coil setup that I went through in the talk just now. If you place coils both anterior and posteriorly, that include the shoulder region as well, be able to properly evaluate this entire region. And as we scroll through, we notice right at the edge of the field, there's marked enlargement of one of the nerves. This happens to be the median nerve. And what's nice about this, again, because it's acquired isotropically, we can interrogate this with orthogonal slices. So here I've kind of created that orthogonal slice in the top right. I'm going to blow this up. So again, similar to the 2D sequences, starting proximally. We see the first rib. Again, notice that the imaging is much less sharp compared to the 2D imaging, but that's because, again, it's a lower in-plane resolution. But again, very thin slices. So here's T1, 8, 7, 6, 5 we spoke about. But now we're able to continue distally. We follow the median nerve, which is demarcated, and I think in a moment I have an arrow right there. And then all of a sudden, that same nerve becomes markedly enlarged. So this patient has, again, mass-like enlargement of the median nerve and likely have to return for a dedicated contrast advanced exam of that nerve. It was picked up, I think, during the exam, actually by my colleague, and it'll have to be followed up after. So the diagnosis here would include an inflammatory neuropathy. Despite this mass-like enlargement, sometimes in inflammatory neuropathies, you can have mass-like enlargements of nerves, such as in CIDP or chronic inflammatory demyelinating polyneuropathy. But we'd also have to include some type of mass. This is an atypical presentation for just a simple peripheral nerve sheath tumor, which also doesn't typically give you a significant amount of motor deficit. So lastly, just want to highlight one last point in this case. We actually did give contrast proximally, and in preparation for this presentation, we actually acquired a proton density weighted sequence. So on the left here, despite the labeling, this is T1, the middle is proton density, and the right is true T2 weighted with an echo time of, I think, approximately 80 here, maybe slightly higher. So this is just to highlight that with just T1 weighted fat suppressed sequences, here we're looking for enhancement of the nerves, which I don't see any of, but it's difficult to pick up the nerves if they're not enhancing relative to background tissue. So we typically, don't use T1 weighted sequences. The proton density weighted sequences do provide slightly higher contrast of the nerves relative to the muscle. So you can see them here, but it's very difficult to be confident that the nerves are hyperintense, and therefore for neurography or nerve imaging, want to use heavily T2 weighted sequences to accentuate the contrast between the nerves and the background tissue, and then pick up any subsequent pathologic changes as we see here. So Maggie, I think I've kind of done going through this case, and I'd like to turn it over to you.
Before you guys go, I would like to say that we do have a survey that would appreciate if you can, if you can kind of quickly use 5 minutes to just take it, because that will help us understand what kind of further education that we can provide for neurography. Today, we only cover the brachial plexus. So if you want to look at extremities or lumbosacral plexus, if that's interest, we certainly want to hear about it, and so that we can plan for future webinars. So please take a quick QR code from your phone and then fill in the survey. And lastly, if you want to know anything more about deep learning reconstruction, you can also go to our website to learn more about Recon DL and where it is going. So without further questions, thank you so much, Darryl, for joining us today and giving this fantastic lecture. Thank you, Holly and Steve and Carolina for kind of organizing everything. There's a lot of things in the background. So thank you so much. And if you have further questions, do feel free to reach out. Darryl has put his email on there, but also feel free to reach out to the GE team as well, and we'll triage to the right person. Okay, thank you.